So I'd like to begin with the head of the Africa CDC. He recently came from dealing with the Ebola crisis. So I thought before we would begin our panel, and the order of events is that we will do a short moderated panel discussion, and then we will have the celebration luncheon. But before we begin, John, if you could give us some comments into the current situation in the DRC.
Share a reflection on how far we've gone, and the leadership, the extraordinary leadership that the government of Democratic Republic of Congo is exercising in this current situation. So we all know the numbers. I mean, as of 20th, there were 51 cases and 27 deaths. I mean, that this situation may change pretty quickly. And we currently have about 600 contacts that are being followed. We personally went to Bikoro and Mbandaka with the Minister of Health. I can't stress enough his extraordinary leadership there. He's at the front line of this, hands-on, and I think we should be very proud of that kind of leadership. What makes this outbreak worrying is the factors that we know. So DR Congo, as we all know, has been fighting Ebola for the last 40 years or so. But this is the first time that Ebola has penetrated a city, a big city like Mbandaka, which is a city of about 1 million inhabitants. I think that is very, very important. The government of the Republic of Congo recognizes that, yes, they have experience in remote areas, but in a city, they do not. As the minister said, we are in a war. And I agree with the minister. We have to fight this as both an emergency and a crisis. Period. So, which means we have to deploy all the assets that are necessary in a rapid, efficient way as soon as possible so that we can get this under control. The second thing that makes this epidemic worrying is the connectivity with the River Congo between DR Congo, the Mbandaka region, the Central African Republic, and Congo, the other Congo Brazzaville. So I think those are some key elements that make it very worrying. When the first cases were discovered or identified in Bikoro, our worry was that it shouldn't get to Mbandaka, but then it got there. And since then, we've seen that new cases have been reported. So I think we are very, very concerned with that. No country in the world is ever prepared for anything. I mean, no matter how much we say about preparedness, it's always a learning process there. I think we are learning a lot from this. We are just, about 15 days old into this epidemic, but learning a lot that even though the global community, we've reacted in a very speedy fashion compared to what the situation in West Africa that we observed. But bringing the resources to where it really matters is still a challenge because of so many reasons. The topography of the country. To go to Bikoro, we had to fly into Mbandaka with a UN plane and then took an helicopter for 45 minutes into that area there. So without such transport and logistics systems, it's still very difficult to apply goodwill into action there. So what has Africa CDC done so far? One, as we speak, we will be deploying 25 epidemiologists into the field of action on Friday. We had to equip them with their protective gears and all the necessary instruments there. It's so important that we deploy them quickly so that the contact tracing is more strengthened because of the effective contact tracing will lead to effective vaccination programs. As you all know, the vaccination program will be based on ring vaccination, which has to deal with the appropriate identification of the contacts there. Second thing we're doing there is to work with the ministry to develop, which we did last Wednesday, 1 week ago, was to develop 3 strategies. One for surveillance and contact tracing, the other for zoning the areas, what they call cordon sanitaire, and then thirdly was a laboratory strategy, so that it can all come together quickly there. So I think that much the ministry is very supportive of that intervention, of course, in partnership with WHO. We also, for the first time, want to use an integrated approach to support this effort, which means we putting in laboratory experts, epidemiologists, and anthropologists. Okay, because when we talk of vaccination, there is a whole concept. It's really it's an unknown. We really don't know how the population and the community will receive that, and so we need to build in anthropological and sociological aspects upfront as we develop the vaccination program. So I think, in brief, that is what we're doing in DR Congo. We are also coordinating a regular bi-weekly call with a sub-region that is bringing the countries in the sub-region together to explain what the situation is and make sure that we put it on the alert. The African Union has also activated the Peace and Security Council. The chairperson of the commission has written to some head of states just to allow them, give us some assets, like the military assets, in case we need to deploy military assets into the areas of the theater of action there. So I'm very pleased with the rapidity with which collectively with WHO, Africa CDC, the African Union Commission, with Médecins Sans Frontières, we are working with it. But there's a lot of work to be done. I mean, a lot of work to be done to get to where we have to be if this escalates into a phase that becomes uncomfortable and worrying there. So I think I'll end my remarks here and let the moderator guide us on the next steps.
Thank you so much, and thank you, Honorable Ministers. I'd like to turn it over to the Honorable Minister from Ethiopia. We're really discussing, an acceleration of Africa CDC. So, Honorable Minister, one of the things we're looking at really is how do we develop public-private partnerships? We really want to celebrate Africa CDC, but we want to make it sustainable. We want to have sustainable investments in healthcare and also grow Africa CDC. So, Honorable Minister, over the next few years, how do you see public and private sector working together so that we have a very successful Africa CDC?
Thank you very much. Before I go to your question, I need to express my appreciation to the government and the people of DRC for responding and reporting the current situation, and also for WHO headquarters, regional office, country office, and the CDC Africa going to the site and responding by mobilizing available resources. So this is a very sincere undertaking. We need, as Africa and the global community, we have to also express our solidarities in terms of responding to this crisis. And there are experiences. I know Congo is better placed, but with the ones affected 2-3 years ago are better positioned as well. So if we can extend our experiences from the continent as well in terms of human resource at times of needs. In Ethiopia, we are mobilizing and taking rosters of those who went to the West African, Sierra Leone and Liberia, and if requested, we will deploy accordingly. And the most important thing, we don't need to, particularly at the community level, vaccine is only given to those who are contact. And the potential contacts that health professionals. But we need to work extensively on transmission blockade. That means avoiding contact with potential contacts and other activities, either in church, on funeral ceremonies, or otherwise. So we have to teach the community. And coming to the African CDC, African CDC is a 1-year-old infant or child, I think, 1 year. So it is a child now. It is just 3 months older than 1 year, and 3 or 4 months older than 1 year. So it has a strategic plan, and it has identified core areas where it need to reach in terms of having a national, its headquarters, and there's 5 regional collaborating centers, and building the human resource capacities, and networking laboratories. So this needs intensive investment. So the philanthropies or other financiers, including ADB, World Bank, and the member states have to also support the investment so that the African CDC meets the strategic plan, the 5-year strategic plan. So I don't need to mention these are the areas that the philanthropies have to support. But the most important thing is the center has to have its own infrastructure, building infrastructure. Then once it has its building infrastructures, it will have its own personnel deployed, equipment deployed, and also systems deployed accordingly. And as a transition, we have to also strengthen our national public health institutes. So the purpose of the center is also strengthening the national public health institutes. So we have to strengthen the national public health institutes, at the same time work on building the infrastructure of the center. And I know African Union Commission is working with some agencies and the governments to mobilize resources to build its headquarters, and that will be left for disclosure by the center as well as the African Union Commission. Otherwise, it is very young institute or center that needs the concerted efforts of the member states as well as potential donors. I see there are some private philanthropies that have started supporting the center, but more need to be carried out to touch the mission and the vision of the center. Thank you.
Thank you so much, Honorable Minister, and thank you for your comments. One of the things that is very integral to public-private partnerships is data, and how you get data deployed on the ground so that we have transparent public-private partnerships. Honorable Minister of Namibia, I know that you've been working a lot in the area of data. So if you could give us, a few comments in terms of, how you see the role of data evolving as we're developing these public-private partnerships, and also the important role it has to play in how we do also blended financing.
Thank you very much, and I also want to add to the voices to congratulate the DRC, the team, Africa Regional Committee, WHO, African CDC. My brother John here did a great job to respond to the Ebola. But before I go to the data issue, I also just want to emphasize that outbreaks of diseases and emergency will always be with us. And they will beat us if we don't have systems or we have weak systems. The pictures I have seen from John's phone are showing an area in northwestern part of DRC which look like a virgin land, and people just landed there, at least. No much logistic, but there is a center, a clinic there where people apparently go and get help. So it's really up to us as leaders of Africa, leaders of individual country, to make sure that basic health infrastructure everywhere is strengthened. That's the first call out. I wouldn't be happy with a strong hospital in Windhoek, which is the capital of Namibia, when the periphery there is not covered. So we need to do that. Now, coming to data, I think this is an unavoidable question. There's hardly anything we can do in this world without data. So when we preach of universal health coverage, when we preach of outbreak, emergency outbreak, when we talk of anything, there's no way we can bypass data. I think we must just accept that. And we need to harness this technology now that's available to us. And we have to migrate to electronic way of dealing with information. It helps speed up things. It's much better accurate than manual way of doing things. It connects people. When we talk of the 5 regional center for Africa, Center for Disease Control in Northeast, West or Central Africa, they need to be connected to the sender, the Africa CDC, via data link and information highway. I don't see any way that we will carry papers from Addis Ababa to Windhoek or to Kinshasa or somewhere in this era. So we need to invest in data, ourselves as governments, our partners, the private sector, and we need to make this data safe for us and accessible to the people who most need it. So there's just no way we can avoid that. So I will stop here for the time being. Thank you.
Thank you so much. I'd like to take, we've heard from the public sector, I'd like to take it over to the private sector and turn it over to the CEO of Sarona Asset Management. Gerhard, if you could give us some comments as to, over the past few years, how you see public and private partnerships, and then also how we can strengthen Africa CDC through some of these public-private partnerships.
Thank you, Joanne. It's an honor to be here. We've seen for many of the last 100 years where the private sector and the public sector have not collaborated very well together, where they've not participated well together, where we in the private sector have been seen to be the problem to development. Fortunately, I'm glad to say that that's changing. That's changing from the perspective of the private sector. It's changing from the perspective of the public sector. I was very thrilled 3 years ago now, in Addis Ababa at the UN Assembly, where the UN convened for the Financing for Development Conference, where the public sector, one after the other, rose to say that the public sector needed the private sector as a partner in development, and the private sector rose, one after the other, to say that we now recognize and accept our responsibility for society and for the earth. It's not just about shareholder value. It's not just about the bottom line. And when we have those two sides coming together, understanding that they need each other and that together they can build a stronger world, face some of the health challenges, for example, I think we have an opportunity in this time in history to partner and to build a better world together. Over the last few years, we have built a few investment funds with public and private sectors coming together, with the public sector joining the private sector to catalyze the flow of private capital into developing countries, into emerging markets. The public sector has joined investing subordinated capital, as well as providing loan guarantees for those private sector players who provided loans to these investment funds, to these investees, these health initiatives, education initiatives in emerging markets. What I will say, some of the things that we've learned from that is that, number one, not all health challenges are addressable by capital. I represent private capital. Not all health challenges are addressable through the investment of private capital. Private investors are not fundamentally disinterested. They are interested in investing in health challenges, but they're afraid. And so the blended finance model, the one that Joanne spoke about, the blended finance model where public and private come together to support each other in these investment structures, allows the public sector to move capital markets, to change capital markets like no one else. That is, the public sector has the ability to catalyze the flow of private capital. And so I would say that what we need between the public and private, recognition that we need each other. Number two, that we entrust a safe, an intermediary, a negotiator, a partner in the middle that is a safe set of hands, that is of absolute impeccable integrity, and that we can trust to carry out our investment programs and our health responses. Thank you.
Thank you so much, Gerhard. And I know that some of you have busy programs, so if the panelists that remain make their remarks brief. We talked about the need for data and blended financing, and I was wondering, Brian, if you could give some words into, I know that you've been working in partnership with UNAIDS and at the head of state level to really look at data in terms of accountability, transparency, which is so urgent for public-private partnerships.
Okay, so the program that our company's been working on for the last couple of years with UNAIDS is truly a public-private partnership story. I guess from private capital world, when the private sector enters the developing markets, there is always perceived risk. And for us to be successful and to lend our expertise, we need a partner. We found that partner in UNAIDS. Our Situation Room program is an integrated health situation room where the premise is to work with ministries of health to integrate all of the data that they have available to them to improve programming efforts, targeted surveillance, and in the best cases, even improve disease response. The way that a public and private sector partnership can be successful is to make sure that both are aligned and integrated into their own working models. And it also has to be integrated into the models of the government. Where we've been able to find success is actually top-down. UNAIDS is excellent at their coordinating capabilities, and through their network of regional and local offices in country, we've been able to work successfully with each of the countries, both at the national level and then even district and county level. The role that data plays offers a tremendous opportunity. I actually wrote it in my notes here. The opportunity for the use of data is paramount. Data can also serve in an accountability and transparency way. So data can be given back not only to the investors, at least to monitor the investments and to help de-risk from a blended finance perspective, but it can also give impact in a couple of ways, not just financial impact, but human impact. And the use of data can be used to measure and provide evidence backing for that. So I'll keep it brief, Joanne.
Thanks so much. I'd like to turn it over to Clifford from Gilead in terms of some of the innovative solutions that, in terms of public-private partnerships can be worked out as, we're developing the future of Africa CDC.
Thanks, Joanne. Just quickly, Gilead Research develops commercialized medicines in HIV/AIDS. We have medicines to prevent HIV now, treatments for HIV, cures for hepatitis C, treatments for Hep B. We're working on dengue, Zika. We have an experimental drug right now for Ebola. And we have a cross-functional group working on a set of public-private partnerships. A few of them, just to mention, is with the Mongolian Ministry of Health on a microelimination program to screen, test, and treat and cure 2,000 patients in a province. We're working with the Vatican Church along with the Tanzanian government on a test and treat program in Shinyanga. We have a mobile health insurance program that's on the mobile phone, full coverage insurance, working with the Tanzanian government and Farm Access, a Dutch NGO. And then with the WHO and leishmaniasis, visceral leishmaniasis, vector reduction, elimination program in Ethiopia, South Sudan, North Sudan, Bangladesh, India, Brazil, Kenya, and this is all executed by MSF. It's an excellent example of cooperation, as Gerhard mentioned, for a while. There was always, I can't explain it, but there wasn't really that much cooperation with pharma, but I see lots of benefits with the collaborations that we have ongoing with both NGOs, governments, and ministries of health.
Thank you so much. And I'd like to turn it over to the Honorable Minister from Côte d'Ivoire. One of the recent, we've seen a lot of global health threats with Ebola, but I think we quickly forget about the global health threat of AMR, of antimicrobial resistance. And I know that Côte d'Ivoire has been doing a lot in terms of antimicrobial resistance. For me, this issue has a personal, because I had antimicrobial resistance.
So I turn the question to you, as we're forming public-private partnerships, how can we strengthen some of the programs that are global health threats, such as AMR, working public and private partnerships?
Mesdames et messieurs les ministres, mesdames et messieurs, je voudrais vous dire que pour la réunion qui nous rassemble ici ce matin, c'est une opportunité que nous offre donc l'Union africaine à travers donc la mise en place prochaine donc de ce CDC qui va donc se retrouver sur le continent africain. C'est une excellente chose et c'est une bonne opportunité parce que depuis quelques années, le continent africain est confronté à des épidémies récurrentes qui affaiblissent notre système de santé, mais qui en même temps nous obligent à avoir un système de santé résilient. Je pense que c'est une sorte de revue que ces épidémies nous obligent à faire par rapport à la réponse que nous devons apporter face aux épidémies. La dernière fois, nous avons eu à réfléchir grâce au LEM sur la résistance aux maladies infectieuses. Nous avons pu tous ici, en tout cas en ce qui concerne les ministres et les partenaires présents à cette cérémonie, nous avons pu faire passer le message et nos différentes expériences face aux moyens que nous déployons par rapport à ces résistances de plus en plus fréquentes des médicaments et en face des maladies. J'ai eu à parler donc de la tuberculose multirésistante, mais il y a également d'autres maladies. Il y a le paludisme qui affaiblit notre système de santé. Donc pour revenir donc au CDC, je pense que le fait que nous pourrions avoir très prochainement ceci d'ici sur le continent africain va vraiment nous permettre une réponse à la limite, j'allais dire une réponse africaine aux questions épidémiques africaines et qui pourront, je pense, nous permettre d'avoir une bonne mobilisation de ressources au niveau africain et, ma foi, je pense que permettre ainsi à notre système de santé d'être résilient. Je vous remercie beaucoup.
He said that the creation of the African Union Centers for Disease Control and Prevention is a very much welcome initiative because it will continue to help member states to strengthen their health systems, which are very, very important. And then she segued into the antimicrobial resistance and the discussion that you had with ministers, I think the Francophonie group, the other day, and how everybody, it was an opportunity to share experiences from many countries. And she did share her experience on multi-drug resistant tuberculosis, but then also said that there were others besides drug resistance to tuberculosis. There was the issue of malaria and other pathogens there. So the highlight of her comments was that Africa needs African solutions to African problems, and by strengthening, by helping each other locally. So I think and then she concluded by saying that we need to have a strong response for the health challenges that we have each time by working together.
Thank you very much. Let me just start by saying that this meeting is probably timely and topical. Talking about data is central to whatever we can do if we want to really transform the current paradigms of dealing with disease to really broaden and think about the health of people. And for me, data has been always the key main driver of change. It is the one who will help us to change the policymaker decision. It will help us to certainly deal better with inequities, social justice, redistribution of opportunity, but it will also help us to be more cost effective. So I want to start by thanking John's leadership, and CDC Africa is timely. If you remember, without proper data, look at what is happening with Ebola. You are just taken by a situation because you don't know how to react, where to react, and this tailoring your response to a situation will never happen. So I want to thank you, John, personally for the leadership who will be behind you. But I want to just underline few things. One, I think from the outset of this discussion, what we need to stress, data belongs to countries. If we don't make a country owning data, and we don't reinforce the capacities of countries, data will become just something used from time to time to justify ourselves maybe in the big meeting, to demonstrate that, but it will not influence completely the decision which are made by politicians, made by technical people, made by implementers to correct and to progress towards addressing gaps which are existing. We saw that ourselves in the fight against HIV/AIDS. When I joined the organization, we used to have less than 30 countries reporting on their indicators. But today, we can talk about 174 countries, which is 90% of the states who are reporting every year on their data. In 2016, it was almost 90% of them. Why? Because we reinforce the capacity of data collection, analysis in the ground. But also, what was very important from my point of view is that is not just reinforcing this capacity, which is key, but we change the numbers of indicators. If I am in the country, John, and with the capacity I have, and I have to report on or collect 150 on 150 indicators, it's impossible. Even the most developed countries will have a problem with that one. So we managed to really reduce the numbers of indicators and select few which could make a difference. Secondly, we know that household surveys are essential. Nobody will say that is not essential. But what our politicians, implementers need today is data in real-time granular data. That's what they need. They don't want to act on data which is old for 3 years, 4 years. They want to know today what could be happening in real time and how then, and when I said granular, because of course, traditionally this survey occur every 5 years, but they are very expensive. We know already that in Nigeria, my brother is here, the survey, ongoing survey will cost almost $100 million. But we need to change this paradigm to push on the shift, to bring a shift which will help us to have an information system which will be able to provide on routine, sustainable system, what I want to say, on regularly information which will influence action. We have already, we work very closely with John, with the CDC Africa, to make sure that we don't have a disconnect between the situation room, which we have been launching in different places, to make it more integrated health situation room, not just HIV. And now we launch it in Kenya, in Zambia, in Uganda, in Cote d'Ivoire, in Lesotho, but we know that also in Addis Abeba, John is taking that, but consolidating, making sure that we can have a data on real time. Not only data on programmatic issues, but data also on management issues. Stock out, how to better, monitor what is happening. In nutshell, I want to stop there because I don't want to take too much of your time. I think one is that without any doubt, timeless, the time issues is very important when we talk about data. Two, we want to improve service delivery approach by making sure that we transfer competencies and skill so this data can be used to better target, to have a population location approach, identify inequities and disparities in the system, and improve accountability and transparency. So those are few things which will help us to have a better return on any dollar invested. That is why I personally feel this meeting is timely and is topical. We cannot go for universal health coverage without the proper data and data which are collected on real time. Thank you very much.
Thank you so much, Michelle. One of the things is we're just going to take 5 minutes. I know there's a lot of expertise here in the audience, and this has been a very rich discussion, and I just want to keep the honorable ministers in the panel just for a few more minutes. And just pick in terms of the audience, because there's expertise, and I'm going to open it up to questions, but I'd like one or two of you to say a few comments. I see some hands up already, but if I could start with Jack Peters in terms of some of the public-private partnerships. I see another hand up, but really your expertise are really needed to answer some of the questions in the audience.
Thank you, Joanne. My name is Jack Peters. I'm leading the Johnson & Johnson Global Public Health Group. And one comment I wanted to make here also in view of the public-private partnerships. This group at Global Public Health is especially created to establish these kind of partnerships. This group is really separated from the commercial groups, but at the same time it's also not the philanthropy group. No. It is a group that is really committed to invest R&D dollars in discovery and in development of new treatments. In MDR-TB is our top priority. In HIV, you know, the HIV vaccine trial, large trial is started end of last year. The Ebola vaccine, neglected tropical diseases, deworming. Also mental health is a priority for us. And so that is just a few comments. We have set up a special organization to really establish these kind of public-private partnerships. Now, the topic of the meeting, Joanne, was also, can we address winnable battles here? And I think we have a very practical example. It was also addressed by the Honorable Minister here. It's about MDR-TB. I think if we can solve MDR-TB, we have one of these winnable battles. And first of all, the relevance of MDR-TB is, we all know that it's the most important #1 killer of MDR, AMR, of AMR pathogens. It can eventually also become a health security threat. But why can we win it? Is after an innovation gap of more than 40 years, there are now new medications available. And in South Africa, the government of South Africa has really proven the impact of these new treatments. So the national TB program in South Africa has really fast adopted and broadly implemented these new treatments. They have now data. The point of data, there are reliable outcome data, treatment outcomes data, where you can see that there's an impressive effect on cure rates and mortality rates. And those data are available, reliable outcome data are there, and I think this is a real example. What do we have? We have here a high medical need. We have new treatment innovation. We have a proven intervention. We have reliable outcome data. And I think if you bring that all together, we also, how can we now scale up and maximize the impact of this innovation? I think that we need also innovation in delivery and innovation in funding, and probably outcomes-based, because the outcomes data are there, outcomes-based funding models can really work to maximize the impact of such an intervention and win the battle.
Thank you so much. I see other questions.
It is an honor to be here. Let me just quickly run into it. It's regarding the situation in DRC. As a Liberian who fought Ebola in Liberia, we are very concerned. The first time Ebola hit an urban area was in Liberia. And so because of that, we had to design different strategies in order to fight Ebola. To do that, let me just give you a few things that is really, really needed now. Coordination, control, and command structure. You also need a laboratory aspect. You need epi-surveillance. You need social mobilization. You need contact tracing. You need case management. Under case management, what is very critical there is dead body management. And that takes into consideration the local context. You have to see how people would like to be buried. And if you do anything contrary, it could have a negative effect on how the response goes. And if you can do those things, I think that is going to help. But I can go through the details later and so forth. But for now, these are things we need to look at. Thank you.
Thank you very much. My question really is around the issue of financing and looking at blended approaches or other approaches that could help to increase the portfolio of funding that we have. Africa is a very wealthy continent from a resource perspective. We have lots of minerals available across the continent. And I'm just wondering, what really do we do, or can we do, to bring in the extractive industries into the fold to contribute to this type of financing that we are talking about? We have the pharmaceutical companies already making a contribution. Yesterday I encountered somebody from one of the oil industries. But really I think potentially there is a lot of funding resources that we could explore with the extractive industries. And I'm just wondering what we could do collectively to encourage them to join these discussions and potentially make a contribution. My name is Magnus Conte and I'm with Last My Health.
My name is Dr. Kuti, governor in one of the counties in Kenya, Isiolo County. I just want to make a comment that this discussion is about public-private partnership, and I'm just thinking that while the private is mainly about the bottom line, and while public is mainly about public good. And I think marrying these two is very, very important, especially in the last mile as concerns health, especially primary health care. So, and I was just thinking, if the efficiencies of the private sector and the effectiveness could marry the philanthropy or the goodwill that the government or public sector has, will go faster to achieve universal health care especially. And I'm thinking about, there's a lot of funds that go through NGOs and government, but because of inefficiencies, and lack of innovativeness, the amount of funds that go is a lot, but the results don't turn out faster. And I was just thinking that this is time when we think about public-private partnership to think of, because private usually ends up in the higher levels of healthcare, especially the tertiary. But the masses who are poor, who are actually taken care of by government, are in the lower level, the primary health care. So how then, using data, could we use the community health workers, for example, to be able to prevent diseases or arrive at early treatment, and therefore use data, especially from the community health workers, so that we be able to reverse the disease trends, especially now the upcoming non-communicable diseases. Thank you.
Thank you so much.
The question of extraction resources, I think is two things. One is what we are discussing here, the issue of partnering with the industry. The second one is we are the lawmakers. Many of us here in Parliament, we can look at the law, how fair it is for the country, because that is universal health coverage. I just want to end on the issue of partnership, and I really want to emphasize this one, that big data, e-health, electronic record, all of these things that we're talking about, I'm not aware of a single government that can produce all of these things. We basically rely on the private sector. So I want to emphasize that point. And if we have to realize universal health coverage, we're basically saying an important component and partner is actually the private sector in order to reach our objectives. Let me perhaps also say that comes with innovation, like somebody mentioned here earlier. And I don't want to exclude the very, very important partner, apart from private sector industry, the communities and the people that we're serving. They have to be our partner as well, and never ever to look them down. So that's one point I want to emphasize. Lastly, we need to support this man on my left-hand side here. You need to support John, you need to support the team and Africa CDC. All of us, politicians, the private sector, every one of us, in order to make it a success. So that's what I wanted to say. Thank you.
Because of this gathering is on how to support Africa CDC from private sector. And it is good that some of you have explained how you are supporting health system, responding to the health needs of the continent. But we need to also support this CDC, the private sectors, either through philanthropies or foundations or in corporate social responsibilities, as some are doing that way. So if you can extend, and some of you can even extend your products so that Africa CDC can use to respond to the needs of the member states. Thank you very much.
I think you're spot on. We need to support Africa CDC. It's on the continent, in Africa, for Africa, by Africa. We're definitely committed to that. I think we have to look at innovation and data and how to use the data effectively, and of course privacy, because at the end of all of that, there are patients and you need to ensure their privacy.
I'm thrilled that we're celebrating the 1 year of the Africa CDC. I'm thrilled that the Africa CDC has been established to coordinate many of the responses to the health challenges in Africa. To the governor's question there from Kenya, thank you. I would say that nothing sharpens the mind like having one's own money at risk. And so innovation, you talk about in private sector investing in the large hospitals in the big cities, but not going down. We need to bring the private sector, sometimes with the public sector holding the hand of the private sector, but we need to bring the private sector down there because that's where innovation is going to happen. It's going to happen when the private sector puts its own capital at risk to try to create innovations, efficiencies in delivering healthcare to the rural communities, to the tertiary cities, etc. And so, yes, I don't have the answer for it, but I know that it requires a public-private partnership, even right down to the rural areas, not just in the big city hospitals.
Let me conclude with the remarks on the partnerships there. We believe strongly that partnerships is the way to go. I mean, it's no longer a strategy, but it's a must-do. And if you look at your tables very carefully, there's a one-pager there that talks about Africa CDC's launch of the public, private, and philanthropic partnerships there. I think that's what this panel has been emphasizing. So in October this year, Africa CDC is going to launch a public, private, philanthropic partnership, what we are calling 4PS for Africa CDC, to harness the assets and the resources that exist on the continent to promote good public health, and especially the issues of data. I mean, good data is to public health is the backbone of good public health. I mean, it's the oxygen of good public health. So I think we are really looking forward to your support during the launch of the public-private partnership in Addis Ababa. And this event will be chaired by the chairperson of the African Union, His Excellency Musa Faki Mohammed, together with the president of the AU. So thank you so much for your attention.